A warm good evening, everyone. It's a great Sunday today. It's the fourth day of the International E-Conclave. Very interesting day because on the last 4 days we have been, since the last 3 days we have been speaking about a lot of things about pharmacotherapy related to tobacco cessation. So today we have the consensus whereby all the moderators from the last three sessions are going to present a short summary, and then we are going to have a great panel discussion with the topmost surgeons from different specialties across the country. Because now we are moving towards the panel discussion, the most awaited discussion of the evening. And for this panel, I'm very, very honored and privileged to invite the chairpersons for the evening, Professor MC Mishra. He is ex-director from All India Institute of Medical Sciences, New Delhi, and formerly the professor of surgery and chief at JPN Apex Trauma Center. Sir was associated with AIMS for more than 37 years, and he has been his greatest contribution has been towards the creation and development of the AIMS Trauma Center. He has honorary fellowship of Royal College of Surgeons, Edinburgh and Glasgow, and also awarded with Dr. B.C. Roy National Award of Medical Council of India by the President of India himself in 1996. With this, I invite Sir on the forum. Our next chairperson for the evening is our very own Dr. Jagdish Kaur, who is a regional advisor of Tobacco Free Initiative from the WHO Regional Office for Southeast Asia. Dr. Jagdish is presently the regional advisor for Tobacco Free Initiative at World Health Organization Regional Office for Southeast Asia. She's medical doctor and public health expert, trained in global tobacco control from Johns Hopkins Bloomberg School of Public Health, USA. And she's also worked extensively with the Ministry of Health, the Government of India, where she spearheaded a lot of development projects and implementation of several national healthcare programs at the and was also part of the various high-level committees of the government. She has published several research papers at the international and national level and has a lot of experience with NCD surveillance at different stakeholders. I invite ma'am to chair the panel discussion. Our key opinion leader and moderator for the panel discussion, Dr. Nimesh sir. He's assumed the charge of director of Institute of Health and Allied Sciences in 2010, and he has since dedicatedly working to make the institute Institute of National Cadre, and has brought a lot of wonderful psychiatrists of that forum to really serve the country. He has been awarded with the prestigious Humphrey Fulbright Fellowship Award at the Johns Hopkins University in 2001 and received 4 national awards, including the Bharat Swasthya Samman. Has more than 70 publications to his credit and is also a member of esteemed ICMR, NKC, and NDMA. I invite Sir to moderate the session. And in short, we have a big panelist here who will be participating in the discussion. So I invite Dr. Rowe Christina, who is a stop smoking specialist from National Health Service UK, Dr. L. Swasti Charan, Additional Director from Directorate General of Health Services from Government of India, Dr. Pratima Murthy, Professor of Psychiatry from NIMHANS, Dr. Harshad Thakur, Director from National Institute of Health and Family Welfare, Dr. Alka Kale, Principal, KLE Dental College, Dr. S. Shanmuga Sundaram, Vice President from Cardiological Society of India, Dr. D. Behra, President of the Indian Chest Society, Dr. Rajesh Swarnakar, Secretary of the Indian Chest Society, Dr. Arnav Gupta, President from Indian Association of Surgical Oncology, Dr. Pawan Gupta, Director of Head and Neck Oncology, Max Healthcare, and also founder at ICanCaRe, Dr. Reena Kumar, Academic Director at ICanCaRe, and Rishabh, our Chief Executive Officer and Chief Technical Officer from ICanCaRe. Please join us on the panel discussion and we can go ahead. Nimesh sir, over to you.
Thank you. Thanks, Shruti, so much. Without saying too much, I just want to make sure that I can get the expertise from the two chairpersons and the panelists across the larger group. And so may I request Dr. Mishra and then Dr. Jagdish Kaur to have their initial remarks about the subject for the panel, evolving a consensus statement for tobacco cessation treatment methods. So would I say initial remarks by the two chairpersons and the remarks by each of the panelists might actually be best in 2 or max 3 minutes. Dr. Mishra, sir?
Dr. निमेश जी बहुत बहुत धन्यवाद. वैसे मैं तो इसमें लर्नर रहा हूँ throughout from the first day onwards because I am not the expert in tobacco cessation. Pawan has roped me in and I thank him for making me a little bit more giving me more information. How much is this problem? How much people are working to overcome this problem. It's difficult. It's not an easy task. I know that. Like I have been working towards injury prevention, and I know how much it takes. Even if you tell people that it is for your own benefit, they still do not basically enforcement or the counseling, whatever you do. Like I always give example when we compare COVID appropriate behavior and helmet enforcement, which I call helmet vaccine for the prevention of head trauma. We lose almost 100 young lives every day on our roads because non-helmet wearing people, young lives are lost every day, and a lot of other trauma is preventable, which we are not able to do. The same thing applies to tobacco use and tobacco quitting tobacco, and I have learned a lot from all the whatever summary has been presented. So I think you get going with the panelists. They are very distinguished panel you have from all across those who are working in this area, and we are eager to listen to them. Thank you.
Thank you, Mishra ji. We'll come back to you for the concluding remarks too. May I now request another long-time friend of mine, Dr. Jagdish Kaur from WHO Sero Office, to have your initial remarks. Dr. Jagdish, please.
Thank you so much, Professor Desai. I mean, it's so nice to be on this panel because there are so many friends, long-time friends and colleagues on this. We share a very long association. And good evening, everybody. So basically, this is a very important topic. And first of all, thanks to the organizers, and I must congratulate them, for bringing this in this way. And then finally culminating with this panel discussion, this topic. And WHO this year, as the World No Tobacco Day theme had commit to quit, I think since the time WHO has been having this World No Tobacco Days, this is the first time we have been focusing on cessation, which is a very important part of overall tobacco control and a very important, demand reduction strategy, and very close to my heart. I've been telling them to have this as theme so that we can take it further. So you have done a good job that this theme, because it's a year-long theme and it is culminating in December this year. So we can have activities to reinforce this, and so that this I was just listening, and it is as per the GATS report that 50% of the tobacco users, they want to quit, and knowing that nicotine is highly addictive, we need to give them support to quit. So these are my initial remarks, Professor Desai. Let's move on to the panel.
Thanks so much. Thanks so much, Dr. Bish. Thank you. And let's have those brief but very critical remarks, gems of wisdom, experience, advice from a panel that I think I'm more than privileged to moderate. Dr. Cessation, we did hear initially, but Dr. Cessation, sir, especially about evolving consensus statement for tobacco treatment. If you have any ideas or advice, please.
Dr. Nimesh, can you please say it again? I couldn't hear it properly.
Okay, yeah. This panel, we are trying to get gems from all of you experienced colleagues about treatment methods for tobacco and how we can arrive some uniformity or consensus about that.
Okay, I think I'll begin with this statement that we were struggling with the O component of the Empower, WHO's Empower strategy, and we have come a long way, and that is offering tobacco cessation to the tobacco users. We try to deter people from initiating the use, and if by any chance they have taken up the habit, we are encouraging them to quit. And to do that, we have tried all means of reaching out to them. One of them is the quit line. Second one is the end cessation, and the opening of the tobacco cessation centers in the districts as per the National Tobacco Control Program. However, the districts are very large in India, and in these districts, if we have only one, we won't be able to cater to the whole population of the tobacco users in that particular district. In these tobacco cessation centers, I must emphasize here that the tobacco cessation, as we all know, is a very comprehensive matter. You have to combine counseling with some minimal nicotine replacement therapy. So that therapy component of the tobacco cessation in the form of nicotine gums has been made available with the nicotine gums, and some places they have also come up with the nicotine patches in these TCCs, is also to be a part of the comprehensive counseling of tobacco cessation offered by the TCCs in the district hospital. Now, as I said, if the number of TCC is very less in the district, I need to increase that number. So to do that, we had combined with the National Oral Health Program and the Dental Council of India, and we have come out with this mandate that every dental college in the country should open a tobacco cessation center. So thereby, the number of cessation has increased in the country. However, there will still be non-uniform spread of the tobacco cessation centers. In some states, like say in a small state like Puducherry, UT like Puducherry and other southern states, many of the dental colleges could be there. So you can have many tobacco cessation centers if you map them in some areas of the country, whereas it is not there where it is needed. So I need to increase the people who can counsel again, and so we have done this integration with the NCDs, and we are trying to make the NCD counselor also doing counseling for tobacco cessation, and also tying up with the tobacco, the DOT centers for the tuberculosis. So whenever a person drops in at a DOT center, we do ask about the TB symptoms, but we forget that TB person may also have, a tobacco problem as well, because both of them are very closely linked. So we are trying to train the DOT center supervisors to also ask for the tobacco habit as well. And similarly, those people who are dropping at the tobacco cessation centers, we should also ask about the TB symptoms. So this integration we are trying to scale up in the country. And apart from this, the other thing which is coming up in the near future, which we are trying to reinforce again, is what is known as the screening at the doorstep by the ASHAs, now, which is known as there is a form called community-based assessment checklist. There, the ASHA comes at your doorstep, enumerates the members of the family, and those people who are 30 years and above, we try to ask for the risk factors as well as prevailing any NCD conditions. And out of those risk factors, we are asking them whether they are tobacco users as well. So once the person says, I use tobacco, and if his phone number is there, in future, we are thinking to link technology in such a way that somebody, if he has uttered that he used tobacco, that number needs to be linked with the quit line. And we need to increase the quality of the quit line, the quantity of calls which can be catered to at the quit line centers. These are all challenges, but we are happy that we are inching towards that, and it's a race against time, I know that, but with all the challenges, I'm hopeful that India would one day be one of the leaders in offering tobacco cessation as a whole, sir. This is my remarks at this point of time. Over to you, sir.
Thank you. Thank you so much, Dr. Swasicharan. That's very useful pieces of information, which I won't try and even recap as we understood. One about integration, as you said, and I'm sure our next panelist will talk about integration with the National Mental Health Program, because we have an eminent psychiatrist, a gifted professional, and much more. Dr. Pratima Murthy, Director NAMANS, for your remarks, please.
Thank you very much. It's been an absolute pleasure listening to all the various discussions, the summaries of the previous couple of days, as well as the interesting emerging topic of genetics. And it's nice to see friends who have been on this journey of tobacco cessation for a couple of decades now. I just have to look at the journey that tobacco cessation has undergone in our country. And it's possibly in the early 2000s that we actually started the first tobacco cessation clinics in centers of psychiatry, in centers of cancer, as well as in some NGOs. And now, so in the last 20 years, I think initially there was a lot of hesitation to use any kind of pharmacotherapy. The government also felt, because of the massive load of tobacco users, that it would be better to start off with initial counseling facilities, and subsequently NRT has been introduced. It's been a long journey, and as Dr. Swasti mentioned, there has been integration into other programs, particularly the tuberculosis program. as well as the district mental health program and so on. But I think the progress has been rather slow. I remember there was a lot of enthusiasm initially in the early 2000s when patches got introduced as the first tobacco, cessation option. Unfortunately, the cost of the patches deterred a lot of people, and it kind of died down. The interest in actually using pharmacotherapy died down. Subsequently, there has been a gradual increase in the interest of introducing nicotine replacement treatments, as well as bupropion. Varenicline, of course, has, although the evidence is best for varenicline in terms of the cessation quit rates, the cost of varenicline has kind of, undermined its use, particularly in people who cannot afford it. And that's really one of the dilemmas that we encounter, that while people have a huge health cost in terms of the kind of problems that they develop as a consequence of smoking and smokeless tobacco use, when it comes to actual spending, there is a concern about the cost of treatment. And therefore, I think, trying to tell people the benefits of tobacco cessation and therefore the cost benefit of pharmacotherapy remains very important. The second point that I wanted to make is through a case illustration. I had a senior dermatologist who had smoking addiction of several years. I offered him just about everything, the patch, the gums, bupropion, varenicline. He was very hesitant to take it. One day when he went to the United States, his grandchildren put up a notice on the bathroom saying, grandfather, please do not smoke. The moment he came back to India, he said, doctor, give me whatever it is that's going to help me to quit smoking. He took NRT and the smoking treatment, and he quit. So I think this thing about motivating people is very critical, and health situations as context where you can actually bring about this change is very important. So I think as health professionals, we need to seize the opportunity of the health consultation as a thing. I was very struck by the fact that, the speaker, Dr. Raval's discussion on the genetics, because I have a patient just last week who came to me about 2 or 3 years ago. I put her on a course of bupropion. She quit for 3 years. Recently, she kind of contacted me and said, doc, what is the treatment you put me on? Just put me back on it. I want to quit. And she's again quit in the last 2 months. So I think you have experiences of both kinds. The third thing is that you have to retain in therapy. As was mentioned, pharmacotherapy is not a magic bullet. Despite use of pharmacotherapy, the kind of abstinence rates you have are, like for any other NCD. And therefore, retention in treatment is also very important, because retention also means that you can use pharmacotherapy effectively. And therefore, in the long run, you can also move people from not being able to use to actually being able to quit tobacco. And that's our experience. You retain people for about 6 to 9 months, and their ability to quit is much more. One of the things I also wanted to mention is that in Bangalore, after 20 years of tobacco work in tobacco cessation, we actually tried to review the facilities that were offering tobacco cessation. And it was extremely disappointing that whether it was solo practitioners, whether it was hospitals, whether it was organized tobacco cessation clinics, there was a lot of reticence among healthcare professionals, whether they were generalists or specialists, to actually, have started tobacco cessation services. So I think it's very, very important to convince ourselves that tobacco cessation is a very important, cost-effective public health intervention that all of us must engage in, and the optimal use of counseling and pharmacotherapy can help people. COVID has brought about a very interesting experience, and I'll talk about the quit line for a moment. In the quit line, as compared to the previous pre-COVID time, we've certainly had near doubling, at least 1.78 times, the number of callers who've actually called with an intent to quit. And that's very encouraging, because I think people understand the complications that COVID can cause, particularly in smokers, and the kind of publicity around it in terms of increased risk and in terms of complications from COVID has also, the awareness has increased. And that's very interesting. We've also had interesting quit rates when people have engaged like this. So I think we need to use the challenge of COVID as an opportunity to help people to quit tobacco. The final thing that I just wanted to mention is the fact that in persons with severe mental illness, the scimitar trial was mentioned earlier. We have also undertaken a trial now of looking at the feasibility of having tobacco cessation interventions which involve counseling as well as pharmacotherapy for people with severe mental illness. Of course, COVID has brought new challenges as far as that is concerned. So we are trying a hybrid kind of intervention, both on site as well as online for these people. Finally, I'll just talk about the few challenges that are there, particularly with NRT. And I think having NRT very easily available has had two challenges. The first is a good thing that people have become more aware. But the second challenge is that people don't use it properly. People don't use it in the appropriate doses. And people don't use it for a long enough period. And therefore, and they also use it in such a way that they swallow the saliva, get a lot of gastritis and side effects, and therefore discontinue it. And then they don't retain in treatment with the counseling. So I think when we talk about planning pharmacotherapy effectively, I think all these things need to be taken into consideration. Finally, I just want to say smokeless tobacco wasn't discussed adequately. In our country, we have a huge burden of smokeless tobacco. So any discussion on tobacco cessation needs to look at both smoking and smokeless. I am just excited that there have been so many people with so much interest in promoting tobacco cessation. And I just hope that this will become a new movement where we will see a lot of successful cessation activities. Thank you very much.
Thank you so much. That and the earlier remarks prompt me to request all the panelists and the two chairpersons to please be with us till the end, because after this panel discussion, I'm going to try, as the conclave chair, share with all of you the consensus statement that we plan to evolve, draft today and the final in next few weeks. Very excellent point, though. Thank you so much. Dr. Alka Kale is at the Dental College, KLE Dental College, and an oral pathologist, I am told. Dr. Alka Kale, please. If you can have your remarks and inputs.
Yes, sure.
Thank you.
Good evening to everyone. Very interesting discussion that we've been having, and was really enlightened and learned a lot from the previous speakers too. Well, I mean, it's very rightly said that the dentist has to be involved. The person from my institution who spoke about the oral care was Dr. Vasanthi, and I think she's emphasized on it. And I would like to say that like as the tongue is a mirror of the health, oral cavity is a mirror for tobacco habits. So I think it's very essential that, we involve the dentist. And for doing it, like, I mean, why do we think that the dentist should be involved? Because primarily they are educated to examine the oral cavity in the most right way. They are the specialists in identifying the diseases which are affecting the oral cavity. They can recognize the disease, and they can also think of, use proper methods for identifying them, because oral cavity is very accessible and we need very simple equipment and techniques in case if we need to do any diagnostics, because samples can be obtained very easily from the oral cavity. Now, if you see these oral diseases, like it's rightly been told that smoked tobacco is being discussed a lot, but smokeless tobacco is something which is causing a lot of problem in our country, because as cigarettes are becoming more expensive, people have gone to chewing gutka and all other products, otherwise also chewing tobacco. These things can be easily, categorized as simple changes, like a dentist can identify simple changes, which could be as simple as staining of the teeth, staining of the mucous membrane, atresion of the teeth. These are initial signs. We have early diseases like a gutka chewer's lesion, where they generally keep a quid, so you have a quid lesion, or they have nicotina stomatitis, very generalized. They have lesions on the lip, where they hold the cigarette or the bidi. And we also have something called as nicotina palatini, which are very easily identified by just putting a probe and mirror into the oral cavity, and it can be diagnosed. And then we have precancerous lesions like leukoplakia, submucous fibrosis, and erythroplakia, which is the initial sign of oral cancer. Not that everything will become a cancer, but yes, they are the precancerous lesions which can be easily identified. So these are the forte where a dentist can play a very important role. Now, as an institution, like, I mean, how can an institute play a role? And I should thank Dr. Swasticharan. Because of him, the Dental Council of India has definitely sent a circular to all the colleges that they should start. We have about 306 dental institutions spread all across the country. And they can play a very important role in establishing a tobacco cessation cell. And this sort of a circular has already come. But what is important, I feel, is that initially we need to train our teachers. Because if we have to educate our students, if the dental students are exposed at the very beginning, in the first year itself, like we have something called as an early clinical exposure, where we make the students do simple surveys in rural and urban areas. So they identify what are the normal circumstances which are present in the oral cavity. So they could be, they do that. So we can have something like that. We can have sensitizing programs and workshops where we can teach about the tobacco cessation protocol, how it has to be systematically followed, and establish a tobacco cessation cell. But I think most important is to train our teachers, because unless the teachers are trained, how will they educate the students? So I think it should become an important concept in our dental curriculum, that we should be emphasizing more on what is the addiction, what is the concept of an tobacco addiction. It was very interesting to just a note from the earlier speakers about how important is that addiction and what are the various phases of addiction. So this should be also taught to the dental students, so that after that, at the end of the course, like, after they become a dental graduate, they should be able to examine the oral cavity properly, especially for the tobacco related lesions. They should be able to counsel the patient at least to a certain extent. And if they're not able to counsel the patient, at least they should know that they have to refer the patient to a proper tobacco cessation center, where a cessation protocol is specifically followed. I think this is important, because many a time a dentist sees some lesion, he just generally motivates a patient and forgets about it. So I think it's important that we also have this proper training, so that they can refer the patients to a proper center. So this would be something. And of course, something which is very interesting is about the use of technology. And it's difficult to take a big notepad and note down each and everything. So if we have something like a mobile health system or use of these apps which are available now, it will be very easy to go door to door and take a complete survey and maintain a very proper basic raw data about use of tobacco and the tobacco associated lesion, which can be easily done by the dental institution. This can be referred to some zonal centers, and finally to the central health ministry, where a proper data can be accumulated for our country. So I think these are few steps.
Thank you. Thanks so much. Thanks so much. Alongside the huge privilege that being a moderator is also the burden of being the timekeeper. And so all the panelists to follow, if I may please, with folded hands, request brief, crisp comments. Dr. Shanmugasundaram is from the Cardiological Society of India from Chennai. Dr. Shanmugasundaram, please.
Good evening, dear friends. I'm a hardcore clinician. I'm not supposed to underestimate the role of drugs in achieving the tobacco cessation, but I firmly believe that my words carry more weightage, particularly when I counsel my patients at the right moment. For example, if the patient sustains an acute event, even on day one, when I see them in the intensive care unit, after I examine and tell them about the illness, I make it a point that your illness is caused by tobacco, smoking or chewing tobacco. Very, very important to stop smoking, much more important than, taking your cardiac medications. Similarly, at the time of discharge, I see to that I, repeat the, counseling about, cessation of smoking. During my outpatient visits, if I spend about, 10 to 15 minutes with each patient, I at least spend 2 minutes with each of them in lifestyle modification, particularly about this smoking habit. Even those quitters, I make it a point each time I verify that they remain abstinent. Because some of them do have relapses, so I have to find out at the right time and motivate them. The interesting instance which Dr. Murthy was telling, I invariably utilize the grandchildren to carry on my messages, when the patient goes home. Because, the grandchildren do have a lot of influence on their grandparents. So it works very well in making them, remain abstinent. Then, some of them, like, who, sincerely wish to stop smoking or tobacco chewing, but are not, able to do it. I send SMS, like, 1 week after my outpatient visit, a month later and 3 months later, like that, I follow it up with SMS done by my secretaries. This is the way I do. And I focus mostly on this age group of 35 to 45. Anybody who is going to quit is going to be benefited, but most benefit is going to come through this, middle-aged people. So I see to that they get the proper counseling. Thank you.
Thank you so much. That's very useful. And now we have one of my, again, longtime friends, Dr. Behra, a pulmonologist and the director of the Tuberculosis and Chest Institute in Delhi in the past. Dr. Behra, sir, are you here?
Yes, sir, I am there.
Great, Behra sir, how nice to see you.
Thank you, sir. Thank you. Thank you, Dr. Desai. And I think at the very outset, I am thankful to the organizers for involving the Indian Chest Society in this important conclave. Sir, I will just focus on an area which is given less attention. That is the source control. We talked about everything about science, but I think the one aspect is the political and economy, which I think we must raise our voice. The point is, we are talking so much. What about then? Why these things are getting available at the first place? We make the things available in the country, and then we discuss, fight, and then go on doing things. So I understand, sir. It is a very tricky area to why the politicians or the administrators or the governments, they allow fast at the first place. But again, we know there are so many things attached to it. It attaches the politics, it attaches the economics, the taxes, and then the farmers, so many issues. But I think that should be one area. Although the government is having the legislation, but my first question is why, after all, you give these things available to the public? I think this is some thought is to be given to that area. Then my second point is now coming to as a profession, being a pulmonologist, I think we see enough of that. And I'm sure as many of my earlier colleagues have told, I think every visit, the patient, whatever patient he is, or whatever, specialty sees the patient first. So one of the important things is to ask about the history of smoking. That is what we have been teaching, and that is a part of our teaching. I think no student passes through without telling us the history of smoking. And then it is just not the getting the history of smoking, also to follow that up, the 5 A's and 5 R's we all know of. And then as our society, Indian Chest Society as a whole, we have got a public forum, and through that we propagate the issue of the various issues related to smoking as we discussed. And the last, but not the least, I should say the various areas. I think the additional DG has already told about the tobacco, TB and the tobacco. This is a very important area as part of the medical colleges. That was our consistent demand to the program, that yes, this is an important component like TB, diabetes, TB, HIV, and now TB, tobacco is a very important component. So also as part of the NCDC, non-communicable disease control program, which also contains that. So this is one of the important components. So that should be propagated very sincerely. Thank you very much, sir.
Thank you. Thank you. I forgot to mention, my apologies, that you're also the president of the Indian Chest Society. And so
Thank
now
you,
we
sir.
have your colleague from the other colleague from the Indian Chess Society, the Secretary of the Indian Chess Society, Dr. Rajesh Swarnakar. Dr. Swarnakar, please.
So actually, I will also reiterate whatever Dr. Osbara has said, that we have got this national also tobacco, I think, control program, but we have to give more teeth to it, because when of course patients come and they have just started this tobacco quite early, and we have seen instances where this tobacco is also sold, I mean, near also schools and also colleges. So I think we have got this national tobacco control program, which is in there since I think 2011. But still, I think we need to have implementation of that of a program, and of course, being also pulmonized, we have got like much more interaction with the and of the patients. And also earlier speakers that they have told that you have to do this counseling in fact also, and that has to be in the place, and we have got this interaction with the patients which has to be just also again and again periodically, and I think that will actually help us in this, and that is what I want to say.
Thank you so much, Dr. Swarnakar. That was very helpful. And now we have the president of the Indian Association for Surgical Oncology. We have Dr. Arnav. Is that right?
Yeah, that's right.
Dr.
Yeah.
Arnav Gupta, sir?
Yeah.
Please.
First of all, thanks to the organizers for having me and the association on board. We have actually done programs jointly earlier with Oncology Society of Bengal and Indian Association of Surgical Oncology. I have a special passion for this anti-tobacco thing, anti-tobacco campaign. But my experience, unfortunately, has been bad. I will tell you why. First of all, over the weekends, not during the pandemic, but we had been doing anti-tobacco campaignings in schools and colleges, and now it's happening virtually. But what is happening is, even after, if I go back to the same school or college, or talk to the teacher or the people whom we had spoken to, I will probably find out of 1,000 one has given up. So it's not easy. We have a charitable cancer hospital in Calcutta. We have actually started, setting up an NRT clinic in our hospital with Professor Chittaranjan Chaudhary. I think most of the people in ICanCaRe, my dear friend Dr. Pawan Gupta, and most of the wonderful team that we have had him on board in one of the meetings. He actually helped us in setting up this NRT clinic. I think the problem is, when you set up an NRT clinic, cancer hospital, the people who are diagnosed with cancer, they have already kind of quitted tobacco, so it's not a problem. If you try and catch them, at a pre-cancer stage, they will not go up to the NRT clinic. They'll actually, try to find the exit door and leave. It's actually all about the motivation that comes from within. I will give you one or two examples. My HOD, surgical oncology, he's a head and neck surgeon, by the way. He knows all the bad effects of tobacco. He actually teaches people how to quit tobacco. He knows all about NRT, but he's the one who spends maximum time in the toilet smoking. I'll tell you about my father, who was the founder of this cancer hospital in Kolkata, Saroj Gupta. Dr. Saroj Gupta was his name. In 1973, when he was setting up this hospital, I remember one particular day, I was only 7 years old at that time. There was a mason, Mistri, who was sitting on a piece of brick. He was smoking bidi, and my father was smoking a cigarette, and he was quite anxious, obviously, trying to set up a hospital without any money at all. They just had a piece of land. But the Mistri actually told him, the mason, that, you can't do any justice to this cancer hospital. You'll not succeed. He was very offended. He said, why? Because you are actually a smoker yourself. So how can you teach people to give up smoking? So the same evening, I remember I was only 7 years old. Like I said, he said, I'm going to quit tobacco from tomorrow. I was kind of surprised because I've seen him as a chain smoker, but the motivation has to be there, like I said. And the next morning he quitted, and he never smoked thereafter. So it's all about motivation, number one. And I fully agree with Dr. Bera. I actually say the same thing in different forums, that it's like double standard. We are trying to set up NRT clinics. ICanCaRe is doing a wonderful job. All the ministry is trying to combat tobacco in different ways. We are doing anti-tobacco campaigns. The shops have been shifted from 100 meters from the school to 150 meters. We'll set up, probably some new designs on the tobacco packs to scare people. But as long as the tobacco is available, I think it's never going to be, excuse me if I'm wrong, is never going to be 100% success. So the best thing, I don't know how, it's easier said than done, to stop tobacco manufacturing altogether, to stop selling tobacco altogether. And you might be surprised how we can do that, because the government is getting so much of taxes. Just try to think, how the world recovered after World War, First World War and Second World War, how people have diversified in different business after COVID. People who had been selling, wonderful cars, they have gone into manufacturing PPEs. You must have realized that. So I'm sure, if we have a will, we have so many, stalwarts in this forum. You can all do some brainstorming. I had a small suggestion, like if you take away 1% of the salary of people who are earning, say, more than 10,000, it's not much of, it's not going to cause much of difference to their livelihood. But the money, given the huge population that we have, and also the rehabilitation of the people who are into the tobacco industry, you can rehabilitate them and make them develop nicotine patches, chewing gums, so that way you can actually make them involved in other professions. So Swachh Bharat is one thing that the Prime Minister has been doing very successfully, setting up toilets. This could be another thing, is worth considering. It's not all about money that we are involved in. The government is interested, I'm sure. We want to save lives, not only for our family members, but the next generation. So I think NRT clinic is a difficult thing. I know you're doing a wonderful job. It has to be a holistic approach. Yes, counseling has to be there. The nicotine replacement has to be there. But there's, at the same time, I think it's high time that we think in a more radical way of stopping tobacco manufacturing altogether. So that was my humble suggestion. Thank you.
Thank you so much, Dr. Anurag Gupta. That's been eloquent. Now we have the next three panelists who have been part of the core organizing team. Before we fall back on Dr. Christina from UK, who might be able to join us a little later, who had listed first, but we couldn't have her that time. So we have Dr. Rina Kumar, who is essentially a dental surgeon and, more importantly, academic director for the ICanCaRe entire activity and program, and has been one of the core brains behind this entire 4-day conclave. Dr. Rina Kumar, please, we need your pearls.
Thank you so much, Dr. Nimesh, sir. It's such an honor and pleasure to be here and to have all of you here. And we are really blessed. And this is the direction that we have been looking for, that, all of us would put our thoughts together and work in a collective fashion towards each and every part of what we are looking at. I can understand from the passion with which Dr. Arnav is looking at the end game of tobacco in the country. But as rightly said, it's easier said than done. I'm also understanding what is being said by Dr. Shanmugam when he said, I'm a clinician and I'm there looking, my words are more important. How I counsel my patient is more important. But at the end of the day, what we look at from ICanCaRe is we're looking at a holistic component, because yes, sometimes it's difficult to, make roads completely road safety, but we can educate the people to be careful and not get into accidents. So the same thing is about at ICanCaRe, is where we look at our prospective view is a wider view, where we are looking to save the people who have not joined that, brotherhood of tobacco, let's say, whether it's the youth, the children, any of those people who have not joined, and through education and education of teachers, that was a very important thing which was being said by Dr. Alka Kale, and educating the younger people in the professional education who have just entered into medical schools and dental schools is something which we at ICanCaRe have been doing it, and we are very proficiently working towards that, because if we can aim at that, that's when we are able to control some amount and save the youth. So save the youth from starting is one of it. The other is to capacity build by education. We are fortunate to have Gujarat University, and Dr. Rakesh Raval has been extremely kind. You've just met him today. And through this incubation that we have there, we have not only developed a lot of ideas, and a lot of other generations have also come in, and because of which we have these wonderful courses which are there. And we believe in capacity building. And as rightly said by everybody from day one till now, what I hear, and I resonate with that completely, that it is important whether you're a dental surgeon or a generalist or a specialist. You all need to be a part of it. We all need to be together, and we all need to combine the thoughts. Again, what Dr. Swasicharan rightly put it, saying that, you don't look at tobacco as tobacco. It is NCD, plus it is the tuberculosis, and the role of everybody playing a role, like the ASHA. So we have a program to develop such people who are going to be talking, and we have an app so that we understand how it is important to have a digital touch, because when you're able to scale up and actually reach the masses, educate the patient or the addict, the user, probably maybe we are through this app and education, maybe the person who's about to start may not start because he reads about something, he understands, he assesses, or he moves towards treatment. So all of that can be done with this digital touch, and which makes it amplifies what we are doing. Along with that, the education of the skill up and the scale up and capacity building. creating more specialists, because I really do not know how easy it is, Dr. Arnab, to actually have a full scale war with the tobacco industry, or actually rally with the government so easily. But definitely, yes, we can scale up and skill up. That is something we can work for, and that is what we are working for, because we believe in visibility, and at least every patient should not be going with a telescope as to where in the world do I have to find a tobacco cessation specialist. You see, Dr. Pratima Murthy just gave us an excellent example of somebody who had quit tobacco some time ago, who she helped quit nicotine, and this person called her back. I'm not sure whether Dr. Pratima, the patient, was there in the same city or not, but apparently in another city she couldn't find somebody, and she had a faith that there was Dr. Pratima Murthy who is going to be helping me. So we should be having more Pratima Murthis all over, in every village, every town. And as we are looking at the dental colleges coming in and playing a role, I think education and training in all these areas, along with empowerment of every level of society, especially students, is very important. Dr. Nimesh, I'm keeping it short. There are
Thank
so
you
much
so
in my
much.
heart, and of course the role of
I know.
pharmacotherapy, counseling, everything, but I'll keep it short and quiet. Thank you so
Thank
much.
you. Thank you. Thanks really for that. And we now need to have our eyes and ears and all senses open for the moving force behind this, Dr. Pawan Gupta. Pawan, for your brief remarks, your pearls of wisdom, please. What would you like to say about consensus statement? Pawan,
You're on
you
mute,
here?
Dr.
Yeah,
Gupta.
sorry, I was muted. Okay, thank you so much, sir.
Please,
So
please.
I will just put it very short and very straight. And this is basically to sum up what has been said by almost all the dignitaries on the panel. Like number one thing should be available, right? This is what what we have incorporated is save the youth, SAVE, sensitization, assistance, volunteer training, and enforcement. This is a 360-degree way of ensuring that tobacco is taken care in all the respects, whatever has been told by all the dignitaries. So just to not getting into it, but the thing is that availability, that is number one. We have to have all number of centers available, TCC centers available everywhere. But more than that, what is important is the skill. We have got tobacco cessation centers mushrooming up everywhere, but we do not have Pratima Murthy guiding or guarding those centers everywhere. Right. This is something very important that needs to be done, and that is the skill of the doctors taking care. When Professor Arnav said that it is a NRT centers, I would not suggest an NRT center. It has to be a comprehensive tobacco cessation center with oral screening incorporated, where we are doing all the four things, A, B, C, D of tobacco cessation, and that can only ensure that there is a complete cessation. That will give the confidence not only to the patient, but it will give confidence to the doctor as well, who is guarding these centers. So this is important. And another very important is the visibility. That is, these centers should be visible everywhere. It should be mushrooming up, but it should be visible, guarded by the right skilled people. And the third and the last one is the networking. And the networking is on two aspects: with the doctors, with the specialists across all the specialties, whether it is cardiologists, whether it is oncologists, whether it is dental surgeons, whether it is pulmonologists, because every one of us are seeing tobacco patients, right? So there has to be networking with these people. Number two, the networking has to be with the social people, and that is where Mr. Kalyan Banerjee, who is the past Rotary president, is here. So what we are doing is we are trying to tie up with the Rotary, the social organizations, creating more of tobacco marshals and tobacco ambassadors in the society, who can actually change this tobacco with acceptable form, that is a tobacco acceptable norm, to a tobacco outrage, where people would say, like putting up posters that you are not allowed to smoke. So this is how we can actually bring the whole thing together, which will ensure scalability, and sustainability of the program. I think I'll stop here. Thank you so much, sir, for giving me a chance.
Thanks, Pawan. Thanks, Pawan, so much. We now have on the panel Rishabh Agarwal, who is the technical director and the technical guy behind ICanCaRe and a whole lot of other things that have been happening. Rishabh, your brief comments, I know you have a lot to offer and contribute and say. brief remarks about how technology can help, what people have already referred to. Rishabh, please.
Yeah, thank you so much, sir, for giving this opportunity. And with the whole panel discussions and over the past month that we have been deliberating upon, I could see that there is a need for on the clinician or the healthcare professional side, as well as there is a need with respect to the patient side who are or the tobacco addict side who are seeking help for a good cessation program. So technology bridges them and brings them both sides together, solves those problems for the clinician as well as for the tobacco addicts. Now, with this idea, the ICanCaRe app has been built up to so that as a clinicians, they can follow a systematic and a standard protocol to provide a quit plan to the tobacco addicts and also guide them in their follow-up, maintain that, have the tracking, do a progress reporting for these patients, and also and also intervene at the right time so that they stay on the quit path for a longer period of time. Now, from the patient side, patient has been seeking they seek for tobacco de-addiction program, and technology provides them with the solution at their very doorsteps, be it medication, be it nutrition, be it counseling services, be it a multimodal services like consultation from a specialist or the counseling services from a trained or certified tobacco cessation specialist. All can be handled, all can be availed through a technological platform in the form of which we have come up in the form of a mobile application. So as an application, it provides a holistic approach, a single platform for all the needs that a particular tobacco addict needs in his entire quit journey. So more and more people can join in this with this application, make this whole network bigger, and with this, I foresee it that we will be able to achieve a tobacco-free society, where one part we can educate a new generation on the impacts that tobacco has, and on the other part we can help people who are already into tobacco use for their complete cessation and de-addiction. So I would urge to definitely make use of this and also improve on this particular platform so that we can have an entirely great platform that can be an example set to other countries as well. Thank you so much.
Thanks, Rishabh. Thanks for this and a lot of other work that you do. And towards the end of the panel, we have appropriately a public health professional, indeed the director of NIHFW, Dr. Arshad Thakur, please. Dr. Arshad Thakur?
Yeah. Good evening, everyone.
Please. Please.
Yeah. So from public health perspective, I would like to focus only on 2-3 issues. So one is this tobacco use itself is a risk factor for many diseases, and we are trying to treat all these diseases along with the root cause of tobacco use. And also another thing is tobacco use itself is a disease. So we have to see that it is a disease and it needs to be treated. And one part is treatment and second part is prevention of this disease. So prevention of disease is also important, because once we prevent people from starting tobacco use itself, then we will win almost 50% of the battle. So that is more important. And for that, we need to create awareness at all the levels, not only at the community level, but also at policy level, bureaucracy level, health providers level. And this capacity building should be ongoing. You cannot have one-time program, but it should be ongoing. And at the community level, we should focus on basically children at the early age. And again, it should be sustainable, ongoing thing. And maybe we can take this opportunity and create this awareness for various other risk factors, not only tobacco, but alcoholism and other risk factors. So simultaneously, we can tackle this. So thank you very much. Thanks for giving me this opportunity.
Thank you so much. Thank you, Dr. Arshad Thakur. That's been great. Towards the end of the panel again, as we had said at the start, can we have some closing remarks from the two chairpersons, please? What you see about the panel that has happened till now, and what would your final thoughts be about the consensus statement that we plan to evolve? Dr. Jagdish Kaur, please, and then Dr. Mishra.
Thank you so much, Professor Desai, again And thanks to all the panelists, and we had wonderful ideas, wonderful remarks, and wonderful feedback from the discussions we had. Basically, we have various partners, various networks who are working in tobacco cessations, and ICanCaRe being one of them. And we have guidance. We have lots of guidance, lots of advocacy material, like now the digital innovative material also from WHO. We have lots of things, but we have to put everything in perspective to come out with the best solutions. So we cannot say that the counseling is best or NRT is best, like Pratima said. It's continuous. We have to have the motivated people, retain the people. We have to have combination of things. So, and like COVID, it was an opportunity for people to quit. But like she said, the calls had increased, but on the other end, we didn't have people to handle that. And government is now trying to integrate the cessation and quit line, but that had to be done on priority, so that people who are calling, their calls are not falling on, like nobody is receiving them. So that should not be there, because nobody will is going to call you again. So these are the little things, because the program was started, government started National Tobacco Control Program in 2007-8. We were the ones who started the first phase, then the second phase came, and now it's all over the country. But there is a lot to do yet, because cessation was a neglected part. Pratima has, they have been the kind of gurus of it, and yourself leading the TCC initiative beginning of the century. So there are, we have these people who have been the leaders in tobacco cessation, and and kind of, when I was looking after mental health and oral health and other things, try to integrate into all the programs which can be. And then the TB, now we have the joint framework also. So tobacco can be integrated with anything, and with a country which is the second largest consumer of tobacco, it is everybody's business. Tobacco cessation is everybody's business. Like now we are doing this NRT collaboration program donated from CIPLA with IDA. So they are doing with public and private sectors both. So I think everybody has to have this training, because this is not in the curriculum, the addiction. So in the undergraduate medical curriculum, dental curriculum, pharmacy. So these trainings are, they are must. And then we have to ask each and everybody about tobacco use, record it, give the brief advice to begin with, and give whatever treatment is available. I think that these are my remarks. Thank you so much. Over to you, Dr.
Thank
Desai.
you so much. Thank you. I cannot but help recall very briefly how, in the first decade of this century, my friends, my longtime friend, Dr. Jagdish Kaur, working in the ministry, had my personal Airtel phone number on the website, and she would keep providing. And people would keep calling up and say, I've been given this number for tobacco suggestions. But yes, we have come some long way from there, like many of you said. Dr. Mishra, sir? Any final words of wisdom before we end the panel?
Yes, I think I've enjoyed the whole discussion by the distinguished panelists, and I can see the passion with which all of them are working towards this gigantic problem, what we call it. And what I feel, there is a large section of children, because this addiction, when the children start smoking from age 10, 12, 14, 13, 14, 15, that is the most important reason for addiction. Once they cross 20, 22, 25, then that problem doesn't come about. So I think in medical colleges also, what I have seen with my own friends, when they started, because we all got admitted at 17 or 18. So I think if we can avoid that age, that is something. And then low socioeconomic group, we have to target, because most of the non-smoking tobacco, as well as chewing tobacco, as well as gutka, etc., are more prevalent in low socioeconomic children, and they are almost outside the radar of all of us. And that is something, how it can be done. Then Dr. Jagdish can work out, or Dr. Harshad can work out how we can, and rural areas also. See, I have known Manpuri tobacco when it used to be called, Dr. Desai, you must be remembering, the Manpuri tobacco was the infamous tobacco. And Dr. Ravi Batra, our anesthesiologist colleague, would smoke in our faculty room, and I was the only one fight with him that you cannot smoke in this room, because I get the secondary smoke, and I will be harmed. So we had a lot of fight. I said, you go and smoke anywhere, but not in the changing room. And this is something which all of us have to deal with. In doctor resident, somebody commented on the chat box that surgical residents, but my experience over last many decades, not very many surgical residents develop this habit, because they have come of that age when they will land up with the addiction of, they might be smoking occasionally, as a lot of us do sometimes, like alcohol also, but not addiction per se. And I don't remember even one resident who was addicted to tobacco, my surgical residents in my experience. So it's not that much common, people understand, but alcohol of course is a different ball game together. But what I was very much encouraged to listen to Dr. Nandita, then when she said pharmacotherapy brings down 36% mortality because of the cessation. I think that is something very significant. And what importantly, what she mentioned, that it is the multimodality and multidisciplinary team effort, like in any other, whether we talk of trauma prevention or we talk of COVID appropriate behavior, it is the teamwork which is so important. And what Dr. Pratima Murthy mentioned, I think we must try and do that, because many a time the parents themselves, they listen to their children, whether it comes to an helmet enforcement or it is tobacco cessation. I think, and grandchildren can make definitely huge impact, because you know how much we are attached to our grandchildren. So I think that is something, she narrated one case where somebody returned from USA and wanted to quit, and by using these tobacco cessation mechanisms. So and then ABCD, I didn't know there is ABCD approach also exists in tobacco cessation. I always thought it is the trauma which has ABCD approach, the airway, breathing, circulation and disability. But I think it's a wonderful concept, the ABCD approach. And naturally it is the combination of counseling, nicotine replacement therapies. And so I think that, and counseling, of course, we also need to know how many people approach actually, maybe from your center, Dr. Desai, that how many people volunteer to come and say, I want to quit. I think that number in India, I don't know, because people are shy of going and getting help, like for psychiatric help and depression also. A lot of people, they just don't approach voluntarily, and they avoid going to the hospital for even psychiatric consultation when they need help. So I think that kind of a environment we have to create, that it is not something, and I think it was very rightly said, instead of ridiculing them, or we must support them and give them good counseling. And that is something which is, and rural areas, I think somebody mentioned, is a area which needs for tobacco, the hookah or the smokeless tobacco use is very common there. And then naturally it was genomic aspects. I was not aware that there is a genomic aspect to tobacco cessation and tobacco use. Again, we need to do some work in this area also, that how, I don't know whether it has been done, what was presented, that how many people we did the genomic sequencing, how cost effective it is as a research proposal and all that. I think that needs to be, Dr. Swasti and Dr. Jagdish can support these kind of initiatives, because these may not be easily available, the genomic sequencing. And I think this is what I would say, that it is a, I think with the kind of passion Pawan has created this every week program for 4 weeks, and a lot of experts I could listen. And today also I see people are passionate, all of you are passionate that something more needs to be done, and more, because very little we are able to do. So that is something which is very encouraging for me, and I got a lot of knowledge, information from all of you. Thank you so much.
Thank you, Mr. Sir. it is appropriate for the moderator only to moderate and not to express his views or her views. And so I'm going to end the panel discussion there.